Good afternoon. Thank you for joining us today. We'll just give it a few moments for everyone to log in. Okay. All right, so welcome to our Baptist Behavioral Health Grand Rounds. We thank you for joining us. I'm Dr. Francesca Varello-Sims, Director of Education and Training for Baptist and Wolfson Children's Behavioral Health. Before we begin, just a few notes on today's presentation. If you have any questions, please submit these into the Q&A box or directly into the chat. And at this time, if you are using a cell phone, please do sign into the chat with your name. So for today's presentation, please help me welcome our speaker, Dr. Tracy Hedgemanowski. Dr. Hedgemanowski is a licensed clinical psychologist with 20 years of clinical expertise working with service members, first responders, veterans, and their families. Her work began in a VA medical center, followed by an assignment working with prisoners of war. She was stationed overseas and stateside as an active duty U.S. Navy psychologist, followed by work as a Department of Defense contractor for 11 years as the program manager of Naval Hospital Jacksonville's Deployment Health Center. For the past 8 years, Dr. Hedgemanowski has provided program development and lead clinical facilitation for nonprofit organizations that provide reintegration and recalibration retreats for veteran and first responder communities. She currently serves as a consultant for the St. Johns County Sheriff's Shield program and is the executive director of the First Responder Project, a nonprofit for first responders and their families. Welcome, Dr. Hedgemanowski.
Thank you so much for having me. Good afternoon, everyone. Are we able to jump right in with the presentation?
Yes.
Okay. All right. Well, I can't see you, but I'm assuming that there are people out there. So I appreciate you being taking your lunch hour and learning about first responders and how to work effectively and efficiently and in a way that is satisfying for both you as a provider and them as a patient. Okay, let's see if I can advance. Okay, when we think about first responders, I want you to really broaden your perspective past what we typically think as what we call blue line or red line, fire rescue and law enforcement. If you look under, and you'll often hear the term LEO used for law enforcement officer, and this can include correction officers, patrol, investigators, detectives, those who are on the dive team, the SWAT team, federal law enforcement, Florida Highway Patrol, as you see lower down in the list. So those will sometimes be, will fall under the umbrella of LEO. But we also have people like medical examiners, crime scene technicians, fish and wildlife conservationists, any cybersecurity or Department of Homeland Security individuals, and certainly DCF. And those are, I think, lesser recognized professions under first responders. And so I just want you to first just think about that in under a broad category. When we think about statistics, when we look at, I'm sure most of you know about post-traumatic stress statistics in the general population. I just wanted to compare that briefly across veterans and the military veteran side, excuse me, for first responders and the military veteran side. The range is very broad. The 30% tends to be attributed to Vietnam era veterans, 10 to 20% for more contemporary era veterans. And when we look at the first responder population as a whole, you can see that the numbers are very similar. I can tell you that a very sobering and tragic statistic is that just as with military veterans, among first responders, just as many people, or I should say more people, end their life by completing suicide than are killed in the line of duty, both in first responder and veteran populations. In the first responder world, that is more likely, suicide completion is more likely to happen while on active service. And for military, it's typically after active service. So I wanted to put that statistic out there because that is, well, it's one of the reasons that I started First Responder Project with my co-founder, Ann Johnson, and why we do these types of presentations. So the nature of the beast is, and I oftentimes present this, not to clinicians, but I wanted to throw it out there because for first responders, it's often very difficult for them to ask for and receive help, just as it would be for a therapist to ask for and receive help. because we are the providers, we are the responders, we are not the respondees or the patients oftentimes. So we see ourselves in this role much like first responders. And so oftentimes what I will talk about is destigmatizing and shifting from the medical model where we talk about disorder and dysfunction and disease and medication and oftentimes giving people the impression that something is wrong with them, as opposed to things have happened to them, particularly in a line of work where occupationally induced trauma is part and parcel of the job. So the nature of the beast, the bearing the burden of those exposures. So oftentimes if we as clinicians can shift away from the medical model, although obviously we adhere to that for treatment plan and for diagnosis and to guide what we do, if we shift to the social model, you can see very derogatory terms either being levied by the public, who are either ignoring the wear and tear of the job on first responders, or family members even who may say to their loved one who is a first responder, you're very cold-hearted, you're very shut off, you're very isolated, you don't care about us. When in fact, the demeanor that they have when they're out or when they're in their home, or how they're talking to their teenager about protecting themselves, may come across very heavy-handed and very disconnected, but it really is founded in being unable to unsee and unhear an unknown tragedy and trauma that they've witnessed, and being fiercely protective of their loved ones. So a lot of that language also from the social arena gets levied on first responders and can make them feel like there's just no winning, so that they're trying to do their very best, but the people who love them and are closest to them see them as people who are not fun to be around or not pleasant. So when we shift to the occupational model, if we put everything through the lens of the first responder and their training and their experience, things can shift a little bit and the language can get neutralized. So I'll give you an example. In the medical model, we might say that a law enforcement officer is hypervigilant based on the way that he or she talks about the way they look around their world. They go into a restaurant, they make sure that they get a seat that faces the door so that the ingress and egress options from the environment are secure, that they have already run their worst case scenario. They know what's going to happen if there's an active shooter or the like. So we might call that hypervigilance clinicians. I can tell you as an aside, if I'm in that restaurant, I want there to be a hypervigilant law enforcement officer on or off duty there to protect me, because I'm not carrying and I may have my loved ones with me. Whereas we call it hypervigilance in the medical model. and the social model, family members will often say, stop being paranoid. Stop turning your head and keeping it on a swivel. Stop turning in your seat. Everything's fine. It's going to be okay. And so again, the person is made to feel that they're very alone because no one is understanding why they're taking, have eyes on everything, and that there's something wrong with them. In the occupational model, that same thing can be considered situational awareness. And that is a trained response. It's somewhat of an inherent response among first responders, probably what brings them into the field in some form or fashion. But when you can share with a first responder, you can depathologize the language and be very careful about how you describe the nature of their behavior, that it might not be healthy for them, but it's inherently trained, and experience has taught them that that kind of behavior, at least on the job, is a very vital thing. When we talk about, as I mentioned before, with stigma, we also need to think about a 5-layer dip, if you will, of stigma, so that there's naturally a social stigma that still exists in our community regarding mental health, although I think that is improving largely. Each individual has their own cultural background that will shape whether or not they're apt to seek assistance. Institutional level, meaning the organization within which they work, whether it's fire rescue or law enforcement or any other, as I listed earlier. Interpersonally, on the peer level, if there is talk going around, even if it's simple as a line of service person talking about another person who sought help, or making some kind of comment about, well, I thought he was good to go, but apparently he's not as strong as I thought. Those types of very subtle but profound statements can lead to that stigma kind of seeping right back in. And of course, all that combines into the individual's notion of, what does it mean to get help and assistance? Does this mean that I am not worth my salt, that I shouldn't be doing the job, that others are going to lose faith in me? I think that the major reasons that first responders don't seek mental health assistance is due to the of career impact, concern about having their firearm taken away if they're law enforcement, or having to not be able to do their job, what their peers may think of them, and also personal pride about being able to kind of suck it up, pick yourself up by your bootstraps, as previous generations have had that mantra. So I'm sure everyone on the call is familiar with ACEs, adverse childhood experiences. That's something that we always want to look at with first responders in particular, because they are most likely going to be coming to you, if not with the primary presenting problem being something related to their job and some kind of exposure, which I'll talk about a little bit later. But nevertheless, if they've been on the job for a day or 10 years, they're going to have a reservoir of exposure, and that could be daisy chaining and lifting up prior adverse childhood experiences. So we want to make sure that we focus on that. Some of the other considerations, particularly with this subpopulation of the community, as you can see on the right-hand side there, is shift work and how that affects sleep hygiene. So whether someone is doing a 12-hour shift and they're changing that shift from 6A to 6P, and then 3 months later, 6P to 6A, how does that change their family life, their sleep hygiene, their ability to get things done that they need to, assuming have stressors regardless. In fire rescue, you'll go from asleep, maybe with one eye open, but asleep on a 24, 48-hour shift, the tones go off, you literally spring into action, jump into your gear, sliding down a pole, jumping in it, and driving fast, and then arriving to a scene, going back to the fire station at 3 a.m. and going back to sleep, to have the tones go off again. And then, so adrenaline and cortisol surges that might not necessarily crest and break as quickly as we'd like them to, but instead people stay up here for a long period of time. That naturally has a wear and tear on the body. First responders often have collateral duties and extra duty assignments that they have to do, whether it be administrative or instructing, mentoring new hirees. Pay is unfortunately still very minimal. Oftentimes, first responders will have second and third jobs, and that comes into play as providers when we're trying to work with their schedule. So if we say, well, we only have this hour available, but they're working 12-hour shifts and they have a day off, we have to think about being flexible in scheduling with them. And they will also oftentimes not be able to avail themselves of an IOP or residential program or whatnot, because they have other jobs that are, providing income for them and their family. Promotions can be a very stressful thing for first responders, in making sure that they advance in the ranks and have to take exams and study for those, and sometimes oral boards and the like. Work-life balance can be very difficult. I'll talk about that more in terms of family and the impact. It can be the general rule of thumb is have as many non-first responder friends as you can to round yourself out, and not necessarily always be hanging out with people who are exposed to the same types of traumas. But oftentimes first responders will tell you that their tightest inner sanctum friendships are typically coworkers, because they just have a tacit understanding and implicit appreciation for what goes on. There's the same sense of gallows humor and irreverence and sarcasm within the organization or within the service. And so they just feel more comfortable. I'm of the opinion that our greatest need is to be understood above all other things. And I think that speaks to why first responders tend to have a smaller network of people and people that they see often. Civil disturbances as well, in recent years prior to the pandemic and during, and because of the pandemic, the social positive regard or disdain for first responders can vacillate, particularly for law enforcement. There's sort of a joke that if someone drops off a casserole to a firehouse, the boot fireman will go run out and grab the pan of lasagna, and they'll all start eating it around the table. If someone drops off a pan of lasagna at a fire station, they send the bomb squad out with a little robot, and they have to, have to figure out if it's something that is meant to harm someone. And I say that kind of, as that's one of the jokes that floats around, but it is a commentary. And I've seen this myself in doing ride-alongs, particularly with law enforcement, that when I find that when we are out on a call and responding to even something that could be a potentially dangerous call, there is a calm and a certainty and a confidence with the officer who I'm with. If we go into Wendy's or we go into a place to eat and they're in uniform, I can very readily see the tension, the way they hold their body changes, they put their back to the wall, and they are very, not everyone, but sometimes you'll see that there's a heightened sense where in that environment, I'm calm. I'm not calm on the call, but I'm calm in the civilian space. Quite the opposite can happen if there's a sense that someone is not liked in the community. And if you're working and living in your same neighborhood and community, that can also be very stressful. So on the quote on the right-hand side of the screen, "The Man in the Arena," is a really beautiful quote by Theodore Roosevelt, and I encourage you all to read it and at a later time and get to know it. Many people who are in a line of service understand it, and it can be a very comforting quote. And I just wanted to throw some alliteration out there in terms of some of the words that can be used to describe first responders. You can see that some of them are very positive and very true. And as you kind of go down the list, because there is sacrifice and selflessness and a tender-heartedness about doing the job that people do and what they are willing to put on the line, that sometimes the demeanor and the sense of humor and the interrelatedness can be hardened a little bit. When someone is on, I just call the shift drift, but when someone is in a service for a while, there can be a little bit of a shift in their perspective and their outlook from, very eager and excited and you feel training and getting all your education, then getting out there and, both anxiety and eagerness, I suppose. And over time, and I think largely because of exposure to not necessarily the best aspect of humanity, or at least maybe the worst timing in someone's life, and that first responders are called out for assistance when things are going badly, that can start to build a burden and fill that reservoir. And so people can become disillusioned, disenfranchised, maybe from their community, maybe from their line of service. But sometimes you'll see a bitterness, and that's just something to think about in terms of what has accumulated over time. I think in some cases that can happen from one event, particularly if it's a very disturbing event, and certainly accumulation of those throughout a career. And so you'll see that some of the side effects of working as a first responder is that some of the core beliefs are damaged or changed. Someone once said to me, "The goalposts have been moved out and I cannot get them to go back together." So the realm of how people can hurt one another, the horrible things that can happen, the extent of tragedy, I've seen, the continuum pull out. And so I can't unsee, unhear, unsmell, unimagine those things. And so core beliefs about the world and the people in it can be changed. Emotions can get very confusing, topsy-turvy, 180 degrees out from what they normally would be. I would hear people tell me that they would go to a funeral of a loved one who they were very close with, and they were very stoic and disconnected. And then they would watch a commercial with a dad and his son playing baseball, and they would fall to pieces. So there's this feeling of just being outside of oneself and apart from oneself, not being able to make sense of that. Naturally, the first two core changes affect relatedness and ability to feel engaged and connected to other people. Some of the times people are staying disconnected because they are in an effort to not have negative emotion or not be overwhelmed by a tsunami of collective emotion. They will not have any emotion at all. So they alienate, or they feel alienated, so they may marginalize intentionally or disconnect themselves from those around them. And as we know, social support is a tremendous protective factor, so you can see where the problem lies. The paradigm shift ultimately is that there can be a change in priorities, what's important to people, their perspective, even their personality, which we'll talk about in a little bit. And purpose, I think, is essential as well. I can tell you that when first responders and veterans retire from the service, or military members retire from the service, that loss of purpose, mission-focused activity can really derail people. And it's very difficult for a lot of people to imagine being retired, so they sometimes roll into a new job. But for those who jump off the moving train, knowing that everyone is still going out in those calls and they've been doing it day after day, it's like pulling the emergency brake on your car when you've been going 65 miles an hour. And so naturally there can be a kind of a spin out and some bad outcomes. I remind first responders, and I would remind you as well, that there are 3 different mindsets as I see it. There's being on duty, between duty, and off duty. And a lot of times we think of it as somewhat of a binary flip switch type of thing. You're either in uniform or you're out of uniform. Unfortunately, there's this in between where you are maybe off duty, out of uniform, but you are in a restaurant in your community, whether you work in that county or not. And so you're in that state of vigilance and still thinking like you do, that what if the person chokes over here, or that person over there is reminding me about that really bad call that we had because of what they're wearing or how they're being. So I've got one foot in the past and one foot in the future, and it makes it very difficult to be psychologically present in that restaurant. So I'm physically present, but psychologically absent. And those different mindsets affect the way first responders are vigilant, how protective they feel, what their tempo is, whether or not they can settle down or they have to keep moving, whether they can be patient or spontaneous, and whether or not they feel an overall tension. If you ask a first responder to really attend to the way they carry their body in space and orient themselves in a particular milieu, they often will say that their shoulders are up, or they're tense, or they're always looking at people's hands or the way they're standing, that they're constantly reconning the room to see what scenarios may build out, or they need to build it in response in their minds. So oftentimes you'll also get these 2 types of presentations, or you'll hear this from family members, that he or she, my loved first responder, is all over the place, can't sit still, every day off or every weekend he's building or she's doing this, and there's this constant movement, or there's this Eeyore mentality of I don't want to get out of bed, I don't want to do anything, this is my day off, these are my 24 hours to myself or my 12 hours. And so it's very difficult oftentimes for family members to really manage it. Going back to that medical, social, occupational model, we may be quick to say, well, it sounds like you have bipolar disorder. When we look to the social model, the loved one may say, he or she is an emotional roller coaster, predictably unpredictable, I never know what I'm going to get. When we look through the occupational lens, however, we may find that that person is being triggered. So everything is fine until it's not fine, because of that a traumatic experience is fragmented in the brain in terms of various senses that might be heightened or triggered. And so everything is going fine. And then that person just kind of drops off a cliff or disconnects, or is the big party pooper, or has murder face, and, and everyone in the family has to shift. So it's another opportunity, or I would encourage you to think about that in terms of responses of the individual, not necessarily symptoms. Symptoms is pathologizing, responses is understanding and explaining. There's different types of exposure. This is not a too easy of a slide. You probably have to crick your neck to read this, but I just want you to think about, for first responders, there are planned, targeted responses. The tones go off, the call goes out from dispatch, and then people respond, whether it's a THI, a homicide a traffic homicide investigation, which is what accidents are called, interestingly, or it's a crisis response, like when we had the Surfside building collapse, where it's not a planned response, but it's a mutual aid, multiple agency type of thing, humanitarian aid, peacekeeping operations, or even a training incident. Training accidents and illness, injuries and deaths can be very traumatizing because there is a lot of Monday morning quarterbacking. What went wrong? How did this happen? We are first responders. How did something occur and someone get hurt? I put praying and weighing on this next slide because those are words that are often used when people talk about haunting is another one. And this is one way to think about and breaking apart PTS into some component parts. So as I have come to understand the first responder and veteran world, to me, under this big umbrella of trauma, there are three categories: threat-based trauma, tragedy-based, and transgression. When it has to do with threat to that person's life, it's often, or someone witnessing someone else's, we may put it into the category of PTS. It has to do with that fear and anxiety response, maybe anticipatory anxiety. I've spoken with responders who have had a traumatic exposure, maybe to a child, the death of a child. They get a call over the radio, regardless of their line of service, and they find out that it's a child. A child is found in a pool, or a child is in a car accident. And they will say there is this simultaneous pull to go and drive as quickly as possible to this call, and wanting to hit the brakes and not getting out of the vehicle because they know that they're about to re-expose themselves to something that could be vicariously traumatizing. So it's like having your foot on the brake and the gas at the same time. Some people are very aware of that when it's happening, and other people aren't, but they find themselves exhausted at the end of the shift, at the end of the week, maybe not wanting to go into work, finding reasons to call out. So back to this model, threat-based will more likely lead to post-traumatic stress. That may be very difficult for first responders to admit that that is happening, because they might see it as a sign that they are not able to do their job. The second is tragedy, and I think this has been very eye-opening side by side with first responders, is that they get exposed to a tremendous, inordinate amount of trauma. Oftentimes debriefs will occur. Agencies will bring people together, and they'll talk about these incidents, critical incidents, or sentinel events, because they are so full of sorrow and grief and powerlessness oftentimes. So first responders are rolling off, unable to do anything. They will do everything. They will throw every life-saving measure at someone, regardless of whether or not it may seem hopeful or hopeless. But those scenes oftentimes stay with people for a very long time. I remind first responders and veterans that they are not responding solely as a person in uniform. They're responding as a human being. They would like to leave their human being at home, but they're responding to an accident where a child may have gotten killed, and are drowning or whatnot, and they see the parents, and they hear screaming and wailing, and they are responding as a parent. They're responding as a fellow citizen, whatever the case may be. So identifying or over-identifying with the victims of a scene can become very burdensome over time. And people also have a disenfranchised grief, so they don't feel that it's not appropriate for them to feel sorrow. They can't even necessarily identify that they're feeling it, because it wasn't theirs. It was through osmosis that they feel that weight. But they don't feel that they are allowed to feel sorrowful about it, because it wasn't theirs. So oftentimes will not talk about it. They oftentimes will not share. Most often, first responders do not share with their primary support person and their loved ones about what goes on in their day. And we do a lot of training in trying to help people talk about it, to speak of it without speaking about it. And I will sometimes say that in therapy. Are there things that you can speak of and mention without speaking about it and going into all those details? And even giving them this scaffolding, if you will, to come home and say, today kind of had some threat aspects to it. Everyone's okay, I'm okay. It rattled me a little bit. It could have been worse. That's probably not likely to be shared, because they don't want to key up there and put their loved one on edge for their next shift, although that's always in the backdrop. But to walk in and say, today was a tragedy day. Today was a day full of tragedy, and I need some time. I need to go play video games, or I need to decompress, if they haven't done that before they walk in the door. Or today, in this third category, today was about human transgression. This was me. I saw a lot of humanity at its worst today. And it's bothersome. I don't know where to put it. There's nowhere for it to go. It's this, instead of this sheet of paper that I just drop into my day, 6,047 of work, it's a crumpled up piece of paper, because there's things on it that I don't want to think about. or be reminded of. And so I have this ball of paper and I'm just going to throw it in the back of my file cabinet, which over time, the accumulation of those is sometimes what people will bring people, hopefully will bring them into therapy. And if not, it could really be contributing to a sense of hopelessness and potentially suicide. So with that, the transgression comes moral injury. It could be one's own transgression. Did I do enough? I don't think I responded in the way I could have. Did someone else transgress and was I witness to that? So again, just a scaffolding to think about these things. These are some of the topics that first responders and veterans, for that matter, often don't want to talk about. If I've known a patient for a while, I might comment that they seem like this gentleman in the picture, with the hand here. And it seems like there's something they want to talk about. And I'll say, without telling me about it, is there something you feel like you can't talk about? They shake their head. Do you know what the theme of that is? Is it power? Is it a matter of powerlessness, senseless tragedy? And if you give them some theme words to talk about, it can sometimes be walking them toward being able to talk about it without forcing it. And other times it's enough for us as astute clinicians to know that, okay, this has to do with a close call. This was a near-death experience, or this has to do with loss, inability to be effective, whatever the case may be. And so you can speak of it without talking about it. So there are a variety of different roles that first responders can have. As you can see there, both witness, or not both, but either witness, recipient, and sometimes participant. The unique thing about particularly law enforcement and military members is that they can participate in their own trauma. So an officer involved shooting, being a combat veteran, even as a medic or a corpsman, as a trauma nurse, is that because people are men and women in the arena and they are hands-on and providing aid, there are going to be times when they feel like they are participating and created an outcome that is very difficult to live with, or they could have done better, and they're second guessing everything they do, which operationally, tactically, and professionally is expected and appropriate, but can also lead to a lot of guilt, shame, and regret. Some of as much as those may be the roles, some of the themes and the exposure that people may have include mortality, something having to do with their life or the life of someone else, moral injury, as I mentioned, and also themes of injustice and inhumanity. So when we work with first responders, and I sometimes will see this on questionnaires for treatment programs, and it will say, specifically for veterans and first responders, and it will say, have you ever been exposed to a trauma? And I think, wow, I think they've already missed the mark, because most people in a line of service, such as the ones I've talked about, have boatloads of exposures. And this grid, although not necessarily to be used therapeutically, quite literally as it sits, it gives us an opportunity to think about some of the role, the hat that the individual is wearing, and some of the themes that are in. Of course, there are more themes, but these are some of the major ones. So I'll let you look at these slides as the next 4 slides. So this has to do with mortality. So you can witness death or near-death experiences of another person. You can be on the receiving end of that, of course, and you can participate that. Think for a moment about suicide by cop. So individuals who call dispatch, call 911, bring law enforcement to their house with the intent of being shot by law enforcement to end their life. So they may have a weapon or something. They might be, most likely they have a weapon, a knife or a gun, or a way to hurt law enforcement officer and provide threatening behavior and gestures that can sometimes force the hand within policy of that police officer. So you can imagine the multiple level exposure to this. You think about transgression, mortality, morality, senselessness. How could these things be avoided? OIS, by the way, is officer involved shooting. And here are some with morality. Even indifference, right? So sometimes it's acts of commission and sometimes it's acts of omission. So people standing around and not helping, being too busy videotaping instead of assisting. There are times when private citizens will deputize themselves and will run in and help out and dive into the pond where the car is going down, and there's incredible acts of humanity, incredible displays. And other times there may be indifference or apathy or even disdain. The violation of TTPs is tactics and procedures, rules of engagement, the standard operating procedure. There are certain circumstances where split-second decisions need to be made, and it can lead to endless questioning from others, and also questioning of oneself. In terms of injustice, watching the legal loopholes, technicalities, evidence being inadvertently damaged or lost. Loss of qualified immunity refers in law enforcement not being protected by an agency, so people can feel very frightened or reluctant to engage, to use any kind of deadly force because they fear the repercussions from that, as much as they also fear for their life and protecting those who flank them, and also in uniform. And in some cases, people may participate in that injustice. I think sometimes when we see examples of that, it may be of a manifestation of perhaps soul burden, perhaps moral injury, perhaps post-traumatic stress. And inhumanity is particularly difficult. This is where I think crime scene technicians are unsung heroes. They have to be up close, personal, and spend a lot of time with those who have been harmed in sometimes barbaric ways. Receiving death threats, being ambushed, being set up. Some of you may know that there's something called swatting, where people will call into law enforcement and provide a fake call so that the entire SWAT team has to go out, and it ends up being an empty house. But it's tension filled. It's very stressful for people. Happens quite a bit, unfortunately. And so the totality of it, as you'll hear sometimes people say, it's just the totality of the circumstance. It's all of it at once. I can't identify one thing. It can show you, these are just these examples all in one chart. But if first responders were to really start inventorying what is in this reservoir of mine, where do I have the lion's share of tick marks? It doesn't necessarily mean from a treatment perspective, we might think as clinicians, where do I begin? Where do I start? If it was a trauma timeline, it would be on butcher block paper rolled down the street, and there would be all these tick marks. This is sometimes an opportunity to think about those things and to do that inventory patiently with patients, so that you can identify, is it that upper right-hand box that has the most tick marks in it? Or is it the bottom mark that has the single tick mark in it? Is there one event that ends up putting 10 tick marks out of 12 boxes, all in one event, and maybe something that happened over the course of 10 minutes? So other considerations therapeutically are that there can be disruptions. So if we think of disruptions and distractions, or distractions may be a coping mechanism for the disruptions, we see that there can be a disconnect from oneself, disconnect from others, as we've talked about, that purpose and meaning not being there. And existentially, a spiritual life or an existential sense of what am I doing? What am I here for? What is the world? What's happening? Even things like what's happening currently geopolitically and overseas in Ukraine. Someone a first responder just said this to me the other day. And on top of it all, I just look at where the world is going. Okay, so that goes to core belief. So that was almost like a tipping point. And on top of all this, now I watch the news, and I see this happening, where there's destruction and humanitarian death and destruction. So some of the distractions naturally are going to be that people become very down on themselves, to self-deprecating, medicating themselves, just folding in and imploding in an effort maybe not to explode, or having a very tense coexistence between the two. I'm just going to feel like I'm going to throw everything and displace all my anger on everyone else around me. So in an effort not to do that, I'm going to withdraw and isolate. Escapism behavior, as I like to call it, is very prevalent among first responders, whether that be drinking to just get out of their mind and numb themselves to help themselves sleep, or it is promiscuity or gambling or pornography, whatever the case may be. if we are delicate and cautious about the way we talk about those things, but also normalize it in that sub community and let people know that this is a coping strategy. This may be an unhealthy one. This may be an addictive one, but we can understand how this escapism behavior is trying to compensate for the bolus of exposure that people are experiencing. So you can read here some of the therapeutic tasks, or to examine those beliefs, those core beliefs, emotions, relatedness, and paradigms. To think about intrusive thoughts versus reflective thought, to help people tease apart the difference between the two of when they are, and intrusive thoughts are very, very common as triggers. I was doing a debrief the other day with an agency that had responded to a horrific accident. And not only were they talking about wanting to avoid driving on that road, even though they have to do that to go to work, to see, some identifying marks of the accident and the like, they were also talking very readily, many of them, about other accidents that had happened. So again, it was pulling up previous traumas, talking about accidents that happened 20, 30 years ago in their career, and they can still remember what people were wearing, the smell of burnt flesh, or diesel, or fuel, and things like that. So helping people to discern that those are intrusive thoughts, and then you can have reflective thought. Obviously, we start that in the therapeutic process, and getting them to be able to switch from one to the other, that rather than think about the trigger and focus on the they were exposing that to the, if anything good came out of that incident, what they learned from that incident as a professional, what they would do different. And that reflection can take a lot of pressure off. Very difficult to do, particularly when people are lying in bed at night and their idle mind becomes that playground for all the things they don't want to speak of. Applying coping strategies, really giving kinetic, real-world, hands-on approaches to being able to do, to turn on the parasympathetic nervous system, to diaphragmatic breathing, to whatever the case may be. This is where doing ride-alongs and asking to be invited to either, not necessarily their agency or their department, but going out and getting this experience and finding ways or locations or instances where people can utilize some of those coping strategies, maybe using their gear and the things that they have inherent to them. Finding new purpose and identity when people shift from throughout their career. So they may be a ground pounder, they may be, in the trenches for a while. Now they become an administrator or an instructor, and how do they deal with those shifts in identity throughout their career? And of course, regulating themselves in their world outside of work. When we think about safety, we really need to think about means. When you're talking about doing a safety assessment, we have to not be naive. We have to understand that many first responders conceal carry, that they go to the range, that they have ready access to weapons. It is part of their job. There may be an unspoken, unbelievable fear of us as providers having power and control over whether or not they go into the rubber gun club, whether or not they're pulled off of patrol or pulled out of, off the ladder truck or whatnot. In some cases, we may have to make that very difficult call. It's always better to make that in concert with the patient to maintain rapport and keep them in therapy. I really believe that as clinicians, with this population in particular, that we have an obligation to pay very close attention to the way we maintain rapport and making sure the person is engaged. If they leave therapy, to reach out to them and figure out, okay, is there something about the therapeutic relationship? Of course, if you would like a different provider, I want to make sure I can get the best provider for you. Let's talk a little bit about the way that you want therapy to happen, if we had not already done that. So there are times when we might mess up, or we might not establish the rapport that person may need. They might also be very highly defended and kind of came in digging their heels. But I would hope that we would all really see it through and make sure we do that follow-up, so that we don't ruin the idea of therapy for someone. particularly in these lines of work, because they really do need to have that outlet, that opportunity for decompression. And it also gives us a chance to say, hey, what about a retreat? Or this other program I know about, or these nonprofits and these other organizations, and there's these volunteer opportunities, and try to plug them in as best we can. So if it's kind of like, if someone wants to give up on that therapy, we are not going to give up on them, and making sure we throw everything at them. So in terms of, I talk about a release valve. I try to use metaphors a lot in therapy, and it really seems to work with this population. So with this is just an example. I encourage first responders to take their own temperature, metaphorically speaking. So to know what's going on when they put their feet down in the morning, or when they're driving into work, to do an internal size up and figure out, how am I? Where am I? Psychologically, emotionally, do I have a clean slate? Do I feel like there's stuff hanging out in the background? The barometer is being able to size up their space. They go into work, or they sense the weather, or whatever might be going on around them, and what's in their immediate milieu. How is that affecting them? How are they interacting? The seismometer, of course, is that, maybe that interaction between the two. If I go in and I have a relationship with someone, and we're just like oil and water, I may walk into work with my thermometers pretty good. The atmosphere is okay, with the exception of this one relationship. Is this going to be a seismic activity at some point during the day? The other thing I talk with people about is like and love, when they're talking about their relationships, and whether they're talking about their relationship with their job, or the relationship with a human being. If you ask someone, a first responder, do you love your job? They might say, yeah, I love my job. I want to do my job forever. I know I can't do it forever, but I want to. Do you like your job? They might say, not at all. They may find disdain for the very people who they serve. So they will take their shirt off the back. They stop on the side of the road, even off duty. They can't help but help. But they don't necessarily want to be around people. People may exhaust them, pull all the energy out of them. And they may just have a very negative view on humanity. So in family dynamics, where the first responder may be kind of stuffing it, and driving on, and being stoic, and putting everything into compartments and burying those boxes, which of course we know we're going to come back up at some point. It's like burying something alive. But they're doing all these things on the left side, and then the loved ones oftentimes have learned that the predictable unpredictability is part of their family cadence, that they need to just sort of lower their expectations, do the best they can, just accept the fact that they're going to play second or third fiddle, that maybe they just get used to excusing the behavior, or the temperament, or the response of their loved one, all the time, maybe feeling very frustrated at the end of the day. Incredibly proudful of their loved one, can't imagine their first responder doing anything else. They know that they're successful and they're well liked, and they do a wonderful job at what they do, but at the same time, they are just kind of laying in wait. They're often in the wings and never really part of the play, unless they were, in actual need of response. So for spouses, oftentimes there can be post-traumatic stress responses that are not from experience, but through spending time around the first responder who's behaving that way. So they may feel anxious before they go on a shift, or if they hear something on the news, they can get activated very quickly. They're probably a little bit more likely to crest and break than the first responder. But you can see that their identity, their sense of control over their world, their immediate family, their children, can be impacted. And children oftentimes miss out on their parent being there. They also can have pride in their parent, tremendous pride and excitement about what they do. But at the end of the day, they just want mom or dad there at their ceremony. They may have fears as well, that something bad may happen. There is a lot of injury and sometimes death in these lines of service. So the children may see their parent getting dressed up in their uniform, their formal uniform, to go to a funeral. And so that type of thing is not necessarily spoken about by children, but can be very stressful for them. They may have to deal with the social response around them. The schedule is all messed up. And if you look at the bottom, their needs, the basic needs that kids want from their parents, often those very things cannot be provided for them by virtue of the job. This is a list, is a busy slide, but this is a list of some treatment goals that sometimes I will make a much simpler version of this list and sit down with someone and say, why don't we check off the things that are most important to you and see where we want to go from there. In terms of, I'm going to speed it up a little bit so we have time for Q&A, but please consider your street credibility for a first responder or for working with veterans. Your willingness to call them beforehand and reach out to make sure that the time works for them. If they don't show, calling them a few minutes into the session, first responders tend to be very honorable and punctual. So if they're not on the call and maybe that they didn't get the email, so that making that connection is important. That just as following up is being flexible with their schedule as well. The 5 H's, as you can see there. Your nonverbal communication, the setting of your environment, thinking about where your windows are, how secure something might be, the language and acronyms that you use, getting away from psychobabble, but learning their acronyms, interrupting if you don't know what it is, and sometimes just making a note to look it up later. I've had plenty of people, not necessarily first responders, but plenty of veterans who would just throw acronyms at me. And every once in a while I'd say, I've been in this a long time. I've never heard that one. I say, I was just testing you. It's not really a thing. So sometimes we can be gullible and sometimes we have to own that, and very much encourage everyone to do line of duty conferences, watching. There are many documentaries. There's not as much information, literature or videos out there as there are for military and veterans, but there are, and I'll put up a reading list at the end. There is a clinician assistance program in various places. I think it's going to be coming up to Jacksonville, or has recently. Clinician awareness program for those particularly in fire rescue, but also some blue line law enforcement training. Going to marriage and family trainings, thinking about including this population is an area where you develop expertise, and you can also get a police and public safety behavioral health certification. Being transparent, being competent, learning, being curious, wanting to learn, being willing to ask questions that might seem naive. Your authenticity and your genuineness will come through, and that is worth its weight in gold with these communities. Within thinking about relatedness and some of the themes and exercises therapeutically, we think about themes of unwellness, of someone feeling not well, and not pathologizing that, but thinking about them being burdened, haunted, preyed upon, weighed upon by their exposures. Focusing on accessible care, a self-focused care that they can engage in, particularly with their schedules. Reading and writing. I've had patients write things down that they couldn't speak, they couldn't pass across their lips. For other people, that was very threatening. And I've turned my chair around so people could say something to me because they didn't want to see the expression on my face. Of course, we talked about that therapeutically, but whatever the case may be, I'm very much a fan. I've done equine therapy with people, which was powerful. I'm a big fan of creative arts, and I'll show you some masks here. There's some that are, you can see themes of confusion and feeling very, this is based on the stories that came with these, but feeling all over the place, not feeling that they have direction or a clear purpose or meaning. Sometimes you will see divisions and very obvious displays of identity crisis or having difficulty processing things. And oftentimes people will put things on the inside and talk about the difference between what they show the outside world and what they experience inside. Sometimes creative expression can become very, very powerful. And you will see things like this. And these kind of speak for themselves. But this distortion, the prominent feature of this being the eyes, being the kind of the maligning of the self and of the body. Those came from people who had been exposed to a lot of death and destruction. And sometimes you'll see masks that are somewhat difficult to read. And these are sometimes the stories that are most profound. and have, stories with them. This one is very interesting in that one of the features of this person's story, and you'll see this oftentimes, is speak no evil kind of covering. But inside, let's see if I can get it here. He intentionally had these pieces of very sharp metal poking inward. And he said, I am caught between not wanting to say things that I've witnessed and things that I think about myself, but when I don't say them, I hold them internally and they hurt me. So there's this catch-22 of being able to express. So I really encourage you to think outside of the box, to be outside, to take a walk, to go by and visit, to do ride-alongs, to help people with personal accountability when they want to start on a plan of wellness. The between factors having to do with focusing on the process and not the content, particularly when there are themes in their trauma history. Sacrifice and compromise in their relationships with others. Are they always giving, but feeling like they're not getting anything back because they're too stoic, or they're not willing to relax and let people into their world? Encouraging couples to do writing exercises, the written argument, which is a more longer conversation, or a whispered argument, so that not only that kids don't hear, but that it's very hard to vehemently whisper for a very, very long time. You'll hyperventilate. So getting creative and getting playful with couples about ways that they can have those arguments, but not have them be destructive. The bottom line up front, being able to tell a story backwards so that people stay engaged, giving them the ta-da moment, and then being able to back those things up. There are lots and lots of really interesting exercises that we can do with first responders. These are some more that I don't have to. I would say that the empty chair technique is phenomenal, particularly when you are discussing the conflict between the line of profession and the man. So, and the person, sometimes there is conflict within those two identities, and doing an empty chair where they transition from each chair and hold that conversation can be very powerful. And I'll leave you with this reading list to take a screenshot or whatnot. This is for occupational specific trauma, particularly with first responders. This is not all inclusive. And I'll switch to just another one more slide for general trauma.
Thank you, Dr. Hedgemanowski.
Oh, it's been my pleasure.
Yeah, very important topic. And so we have just a few minutes for questions, if that's okay with you. So I know you said, the ride-alongs a couple times, but, what are your thoughts on mental health professionals being like co-responders, some of those movements, and potentially to not only address civilian distress that could be characterized as more mental health in terms of, like a security issue, but also really helping that first responder after traumatic experiences?
Right. So that's a great question. I think of it as sort of internal mental health assets and external mental health. So I think there are some exciting ways that mental health professionals can be consultants within an agency, talking about setting up peer support, talking about creating, shifting the culture, introducing mental health in a more palatable way, and so that doesn't feel like it's a threat to those in the department, being an embedded provider, or being called in to do debriefs and those types of things. There's also the co-responder model, or where mental health clinicians go out with the deputy, with the patrol officer, and respond to behavioral health emergencies. So whether a Baker Act is required or Marchman Act, they work with, some agencies have identified deputies on each shift who go to those behavioral health calls, suicidal individuals, or homicidal individuals, substance use disorders. So there's some debate out there in the field as to whether it's safe for the mental health professional, because they're not trained in tactics. Not that they're expected to jump right in, but I would think they should have a vest on it at the very least. I don't think they should be armed, but it's really a mentorship, and while riding along with the deputy, because they would have a shift essentially, it gives them opportunities to provide information and say, okay, these are the types of things that you can do to de-escalate, or to when someone is having hallucinations or whatnot. So hopefully the agency would identify someone who's very interested in that as well. But it really is a nice way to round out a first responder department, to have external behavioral health, or external providers who are either available as through Baptist, or embedded, having the chaplain, having them relate and connect with the chaplain corps, peer support, training and doing evolutions with peer support. There's EAP, there's a lot of ways to provide those. And different agencies in different counties all over Florida are trying to work on that co-responder model in particular, to see if it is changing recidivism rates, for the number of calls they're going at, repeat calls, and really getting people connected with services rather than putting them in handcuffs and taking them to the county jail.
Sure. And even for the first responders in general, because one of your key points, right, is like that street cred element. It's a very specialized population. And so if you integrate the behavioral health practitioner, it might help reduce some of that stigma, and not wanting to seek help. It's right there for you. It's just a part of the norm. So,
and I would say a lot of times when there should be really a no closed door approach with EAP, oftentimes there is, now with the mental health utilization skyrocketing, that there was a many month wait, that when you have assets, when an agency has assets that are, they don't necessarily have a phone that, a red phone that they can pick up and they're right there. There are hotlines for law enforcement and other first responders that are national. But to be able to strike while the iron is hot is really important. If someone is coming into therapy as a first responder or a veteran, that is an enormous step for them. Because they know what they're coming with, they know what's in that reservoir. They're very fearful of that, and we as providers are going to pull that linchpin, and that they're going to overflow and be overwhelmed. They know that there are things that they need to reconcile in their head and their heart and their soul, and those are very, very heavy things. So if you have a first responder, whether or not, as I said in the beginning, whether or not they're identifying as I'm trapped under something heavy, that being my 20-year career or my 5-year career, they may be coming in and talking about their relationship or other things. But I want to make sure that we pay attention to what is in the background, because they're so used to it. It is what it is. It's the nature of the beast. It's just what I do. Yet some of the stories they tell are phenomenal. They're just incredibly, they can be overwhelming to the provider. And so we have to work on our game face and our ability to be present and compassionate, but not be overwhelmed, and also be careful of secondary vicarious trauma as well.
So we have two questions that are kind of related, so I'll pair them together. So thoughts first on union provided therapy versus outside therapy, because there's this, as Robert's noting, a potential like ego bravado and not wanting to seem weak, so is there a benefit to either one, whether it's through the EAP of the actual agency or union or outside, so that you don't have to worry about that image of being, considered weak to your fellow coworkers or upper leadership?
Sure. EAP. So the important thing is whether or not there's a feedback system. So if it is mandatory counseling or you're voluntold to go, as they say, that may be different. That may be a fitness for duty. So a fitness for duty provider should not be a treating provider. The fitness for duty is more of a forensic evaluation of, is this person fit to be able to be doing their jobs? In some lines of work, like internet crimes against children, that is inherently a very stressful job. Oftentimes those individuals have checkups, that they go sit down with a therapist and just check in, how's it going? Do you still want to do this job? And it's one of those, if you don't want to do this job at any point, you just say, we just happy you're willing to do it as long as you can. So there are some different versions of when mental health comes into play. And so agencies have to be cautious about, if they say, hey, why don't you just go use the EAP? Then you do that on your own, and there's no feedback system. There's no feedback loop. Or going to use your major medical benefit through Baptist, or going, through, or going to a treatment program or whatever. But it gets a little bit, the stigma and the intense fear that people have about it impacting career comes in when mental health people start lurking around, or maybe come in and do a training and no one wants to raise their hand and say anything. And it's like the worst kept secret, but in having been as an embedded person, for a while, I joked that I might as well have had a hat that said narc on it. It was like I had leprosy and porcupine quills and all the things that, people would want to stay away from me. And it just takes a lot of time of chipping away, kind of getting into the, inundated into the culture, and it's about your personality and your willingness to be flexible and but still mindful of the processes that are going on. So to each his or her own. I think some people are very comfortable being able to do more casual intervention, just sitting down or having a mental health person come and do a ride along or ask questions. And other times it does really necessitate a more formal therapeutic environment. So there's sort of like coaching and mentoring, and then there's therapy.
Yeah. So it sounds like it will be person dependent, who based on the first responders' level of comfort and the need really will dictate what level.
Yeah, I think so. There's the old guard, of both first civilian and military communities of the suck it up buttercup generation. And what's interesting is that the newer, younger generation that's coming up and really more readily putting mental health on their sleeve and talking about it and being open is actually, I find it's shutting down the old guard even more. Like, well, we got through it. Now all they do is talk about, mental health, and they're throwing it everywhere. They need to do what we did. I ran the gauntlet. They need to run the gauntlet.
Mm-hmm.
But some people are a little bit more enlightened. And I did in the debrief that I just did. There was someone who had her first call was this, horrific incident. And then there were people in the room that had 30 and 35 years experience. And they were just sitting there like, I don't get it. I didn't even know why I'm here doing this debrief. So it really does depend on that layers of stigma. What is their family, their culture, their brotherhood or sisterhood say about access? But when we can normalize it and say, it is what it is, this is the nature of it, your cup will runneth over, your cup will become full at some point.
Mm-hmm.
There's a difference between being stoic and being stupid. If you get into escapism behavior and you're chasing your tail and you're just trying to keep it together, then it's exhausting you. That's not stoic anymore.
Yeah.
And there's only so much to be said for that. There's no ribbons given, medals given out for being impervious to these things. I let people know, if you have a good heart, a compassionate heart, a tender heart, and you're in the line of service, it's going to get bruised and stomped on and beat up, and you're going to have to reconcile that and release that and recalibrate and understand it, or you won't be effective.
Mm-hmm.
You won't be ready, fit and ready. And that's what you take pride in. So it's mind, body, heart, soul existence all together. So we're trying to get that into the communities. It's difficult, but
Mm-hmm.
with online blogs and retreats and things that we're just trying to, throw a lot of things out there so that people will, you can build in. That doesn't mean that they're going to come.
Sure. Right.
But
well,
I think as providers, what's that?
I said, gotta try, right?
Absolutely. And I think as providers, our curiosity, and we don't want to idolize our patients. We don't want to say, oh my gosh, I could never do what you do. And, I bow to you. And, just think it's amazing. I think being invested and wanting to know, like, forgive my naivete, but I haven't done a ride along yet. Can you get me a point of contact so I can ride along with a different agency, so I'm not creeping around your place, making you uncomfortable? But I would really love to see what it's like, to be 12 hours, at the fire station, or to go to forensics, or to go to major crimes. And I think a lot of places are more than happy to, let you in if you're trying to establish cultural competency, which is really what we're doing.
Well, that's really wonderful to hear, especially for clinicians potentially on the line that don't have that background. That's really how you could gain some of that, competency. Just being,
Absolutely.
yeah.
And if anyone needs any, connections, or say, I live in this county or live in that county, I'll be happy to track that down for you. And I have never had a place say, no, we don't want you to come through. They understand that their folks need outlets, and they want to find people who get it. Or willing to get it.
So just one final, question. Any areas of research that you feel are needed for this population in general? What do you think could really advance the clinical treatment of this population?
I would really love to see a combination of mental health and physiological studies, looking at dispatchers, call takers, fire rescue, looking across different places in terms of where we can use biofeedback, how we can use relaxation strategies, not just therapeutic cognitive emotional strategies, but also taking a look at the way that their job is oriented and how there is this rise and fall of chemicals. I think it can guide what medications are useful for people for sleep and psychotropics. I would love to see more and more research in the field of moral injury and soul burden. I think that unfortunately PTS is being thrown out there in an exaggerated way sometimes, and it's become a layperson's term, and first responders push back very hard on that. But I find that when I talk with them about loss and trauma and tragedy and transgression, that they start to realize, oh, yeah, like, I guess a lot of what I expose to is that. And so what do I do? What are some therapeutic interventions for that? And I didn't get that in grad school, and I'm sure a lot of people didn't. I think there are some techniques and strategies that we can apply for that, but I would like to see more, so academia and more writings about that, case studies, presentations, particularly when you're talking about accumulated trauma. I think we sometimes will focus on a singular event or maybe a set of circumstances, but the volume in which first responders are exposed to these things is uncanny, and I don't even think they necessarily appreciate how the burden the weight that it bears. So I'd really like to see first responders as a population be studied, cross service, and looking at the similarities and differences there, and also seeing what kind of therapeutic interventions in terms of individual therapy, but also in terms of group therapies.
Yeah. Well, it seems like it would be a good, complex trauma subpopulation because of
absolutely.
What I mean? The layered and repeated exposures. So,
absolutely, because they have their own personal traumas as well.
Yeah.
That have to contend with their own losses and that type of thing. Yeah. Yep. It's fascinating. It's a great, and they're a great, I say this kind of generically, but I find that and I come from the Department of Defense world, so having worked with veterans for 20 years, who are always near and dear to my heart, that first responders there's such a lot of similarities, and there's a kinship, and these are folks who have a phenomenal amount of resilience, and they just have hearts of gold, and it's so difficult for them to take a knee and to be on the other side of it. So when they do, I think it's our charge to take very good care of them and to meet them where they're at and push when they need to be pushed, and to back off and to think more creatively about how we work with them. There's just a lot. I think there's a lot to learn about resilience as well. And oftentimes, and we look at what's not going well with people, and we study what's not going well instead of looking at the flip side of that, which is something they're doing some things phenomenally, incredibly well to be able to have these careers that are so long and storied.
Exactly. Well, thank you so much for your time today. If anyone has any questions for Dr. Hedgemanowski, please feel free to reach out to us. And thank you all for attending. Please join us in April on the 27th. We're actually going to have our first in-person GrandRounds event at the Florida Blue Conference Center. We're going to be discussing mental health policy and advocacy at the local and state levels with Dr. Andy Keller. So we hope to see you all there. Look out for the flyer from Cindy Hamilton in the next week or so. Okay, see you all next time. Thanks, Dr. Hedgemanowski.
Thank you.
Bye.